So I'm going to start the recording. And folks, just a reminder that you will have to participate for your credit. So Dr. Eschelbach may stop and ask questions. He may ask if you have any questions. You need to jump in there. You can unmute your microphone and talk, and then remute it so the noise behind you doesn't bother what's going on with the video recording and everyone else listening. Or if you don't have a microphone, you can always use the chat feature as well, which Dr. Eschelbach will try to have up on the screen, and I'll glance at too to try to see if we can catch anything. You have to be here for the entire session to get your credit, unless if for some reason you are on a 911 truck, you need to text me and let me know. And then if you get a call, you can text me and let me know that you're on a 911 call, and I'll trust you. Other than that, looks like we're doing pediatric trauma 2021. What's different? This is going to be a very interesting one. So that having been said, Dr. Eschelbach is our assistant medical director from Redmond, Oregon. He's been with us for several years, teaches on the circuit up there, is medical director for several EMS services, and we really have had a lot of good lessons from Dr. Eschelbach. So please pick his brain. That's what he's here for.
All right, can you see this okay?
Yes, sir.
All right, very good. Well, we're going to talk about pediatric trauma. What's different? Not a whole lot has changed in the past year, but still quite a bit of physiologic difference with children. And of course, as first responders, you're going to be the first there. And we'll talk a little bit about child abuse at the end. All right. Just a little bit of background. Information is about 10 years old, but still fairly true by all accounts. About a quarter of all visits to the emergency department involve children, and about 13% of EMS transport involve children, and 54% of pediatric trauma patients arrive to the emergency department via EMS. So integrating pediatric needs into pre-hospital trauma is essential. So what type of injuries do children sustain? Mostly motor vehicle associated injuries, drowning, which we talked about last summer, house fires, which we have also talked about, unfortunately homicides or pediatric abuse, which we'll talk about at the end of our lecture, and falls. And the thing to keep in mind is many times kids have more than one system injured. As I said, approximately 50%, 48% or so is trauma. The leading cause of death of children is trauma. It can also lead to developmental problems. About 30% are other things. Cancer is very low on the list. Congenital problems and infections, which you would think would be a whole lot higher, is relatively rare. Pediatric deaths are different than adults. 1 year of age to age 14, the most common cause of death we've already established is trauma, and 45% of those are motor vehicle accidents, 17% are drownings, and 21% are some form of poisonings or burns or firearms. The good news about pediatric trauma is they generally have better survival because they have less comorbidity, and they have a very great capacity to heal. And most of the time, you have to use much less invasive management. You tend to intubate them less and take them to the operating room and start central lines less. The bad news is they're very difficult to assess very often. They can't tell you their history, or they can't describe it. Sometimes all you have is a crying patient. They can have long-term disability as a result of the trauma, and it's emotionally taxing. Anybody who's ever taken care of a child knows that it's very, very difficult. And this is an N of one, meaning me. But early on in my career, when I was in medical school and was an intern, I could not stand pediatric patients. I didn't understand them. Why? I didn't have children. It doesn't mean that you have to have children to treat them, but when I had my own, I finally kind of understood them. So if you're an uncle, aunt, sibling, something like that, it's a whole lot easier taking care of children if you understand what you're dealing with. General considerations, there's a physiologic difference. We'll talk about specifics in a few minutes. There are some anatomic differences that are very important, and the epidemiology of what makes them sick or injured is slightly different. And then sometimes we'll have a different pattern of injury with children. Keep in mind that most kids are, in general, made out of rubber. And I say that in a good way because they've got open, softer craniums. Up until a year, they'll have this open fontanelle, which is kind of a inexpensive pressure gauge. You know, you can press on it and figure out hydration status and whether or not, you know, it's bulging or not. There's a lot of cartilage, especially at where the bones lengthen, and very often they don't break as easily. And sometimes this flexible cartilage skeleton leads to more underlying damage to like lungs or other organs inside the thorax or inside the pelvis because they are so rubbery in general. Kids are just not little people. And let's start with some of the obvious things. First off, all kinds of formulas for pediatrics. For example, ET size is 4 plus the H divided by 4. Nasogastric tubes and Foley's, chest tubes, weight-based medications, and age-based vital signs, which I'll show you in a few minutes. So all these things are different. Kids are completely different than adults, and we obviously can't use adult equipment on them. So how do you remember all these formulas anyway? If you can remember all these formulas, great. If you can't, that's why we have just simple tools like the Broslow tape. Now, I'll talk about two specific types of tapes today, or ways of cheating with pediatrics. Some people are very, very simple, and all they have is something called a pediatric wheel, where they look at the wheel and it tells them exactly what dosage of medication and what sizes to use. But this is just the Broslow tape. I had dinner with Broslow about 10 years ago. Nice guy. He came up to a conference here in Oregon, and he really wasn't that smart of a guy, and he would admit it to you that he was just a family doc who worked in the ER an awful lot, and trying to remember all those formulas were kind of a pain. But he was a fisherman, and as he fished, he realized that the larger the fish, you know, the larger the equipment he used, and he kind of made that corollary, and he came up with his Broslow system. And most of you have seen this. It's, you know, the kid fits on the tape, you put it at the top, you see where they are, and then you grab that bag. You grab the yellow bag, the white bag, the blue bag, etc., based on the size of the child. And inside here, it's going to tell you all the dosages. And they are specific to the Broslow system. In the emergency department, we have one of these carts. It's updated by pharmacy. As you open one of these, it'll tell you exactly what medications are in there and how to dose by weight and size. And it's just like the system here, except these, instead of bags, this is a code drawer. And it has everything that we need, ET tubes. And then right here on top is a medication guide. If we want to start ampicillin or antibiotics, if we suspect something's going on. And in each of these drawers, you'll find the appropriate size of ET tube, G tube, Foley catheter, IV, etc. As you look at the top of the tape, it'll tell you exactly how to use certain things like sodium bicarb based on where they are, and that's approximately how many kilograms they are. It'll give you a good dosage if you're going to use lorazepam or succinylcholine or something like that. It'll give you a little hint about atropine ahead of time, and it's pretty idiot-proof, but it is something you have to practice. In general, in adults, resuscitation, the arrest is the problem, meaning usually in an adult, the problem is the heart is stopped and logistics are secondary. With children, logistics are the problem. Do we have swelling? Do we have an open airway? Do we have a respiratory problem? And arrest is usually almost always secondary to a pulmonary problem. Again, Broslow tape will have medications spelled out to you based on where they are on the Broslow tape and what their approximate weight is based on the length. And then somebody said, well, you know, where are the errors in pediatric dosing? And the conclusion was medication errors can occur during all stages of pediatric resuscitation, but most of the errors are done because people did not use the tape correctly. And you can see that dosing is the biggest problem when resuscitating children. So once we establish that the Broslow system works, we can understand the differences in pediatric anatomy and treat them subsequently well. Now, a couple of years ago in resuscitation, this is not that old of a study, only about 3 years ago, and they wanted to bring in and figure out if the Broslow system really worked. And the conclusion was it had sufficient accuracy as a weight estimation when compared to other techniques. It does have some problems with drug dosing information, and you do need additional material. And the frequent rate of incorrect usage of the tape indicated that appropriate training was necessary. And lo and behold, someone starts a new company, Hantevi System. Again, I've met this gentleman as well. He's a smart guy. He's an ER physician who designed a system called the Hantevi System, which is kind of easy. It's kind of like Chibop that you use your fingers with. And it's a different system. And it's also accurate. And it's a good system if that's the one you're using. So if you're using the Broslow system, you need to practice. If you're using the Hantevi system, you need to practice and be comfortable with it. So as in all things EMS, when you're treating trauma patients, you begin with the basics, A, B, C, D, E. Now keep in mind that pre-hospital transport life support or advanced pre-hospital trauma life support is slightly different, but based on advanced trauma life support that physicians use. So I'm going to use some terms that are back and forth fairly standard. But in advanced trauma life support, we have something called the primary survey. And the primary survey is a constant clock that runs where ABCDE is constantly gone over. It's the first assessment that you do. And as you come into problems, you address them. Airway, breathing, circulation. So as you come across an airway problem, you treat it. Breathing, you treat it. Circulation, you treat it. Disability has to do with their Glasgow Coma score. And then again, E, expose. You should be cutting the clothes off and looking for all possible sources of trauma in a child. As a rough guide to your clinical decision making, vital signs are very, very important. The pulse is much more sensitive than the blood pressure in children. And children will often maintain a normal blood pressure. So if you had I don't have the graph, but if you had a graph of blood pressure, it would be here. And then when a kid gets into problems, they fall off quickly. So blood pressure can be normal for a long time and then boom. So you got to watch that pulse. If the pulse is becoming slow, then you know that you're running into trouble with a child. This is pediatric vital signs. So probably if you look at your cheat sheet that you keep in your back right or left pocket, that's what you do. Again, a blood pressure, 70 plus 2 times the age. And keep in mind, look at these numbers. From 0 to 1 month up into a 12-year-old, 180 to 100. Respiratory rate of 20 to 60. Blood pressure of 90 over 60 to 60 over 40. What is amazing about all these vital signs is they're all abnormal for adults. 100, which is normal for a 12-year-old, is tachycardia in an adult. 180, which is normal for a newborn, is way too fast for an adult. So already children have abnormal vital signs. Tachypnea is labeled as anything greater than 20. And keep in mind that a 12-year-old has tachypnea. So vital signs are somewhat confusing in kids. If we saw 60 over 40 in an adult, we'd be starting blood, right? Well, it's normal for a 1-month-old. All right, let's go back to our ABCDE. Airway. Differences. Kids puke. They puke a lot. And you have to be careful that they don't have vomitus in their mouth. Because of their large occiput and large tongue, we have to treat their airway different, which I'll show you in just a minute. When we intubate them, their cords are way, way anterior, and they have a very short trachea. So we have to pay specific attention to positioning, how we handle the oral airway. Generally, we use a straight blade with a curved stylet, and we're trying to pre-calculate a very small depth because it's not like way down there in adults. And surgical airways are also something we could consider in a child. Again, most of the time, kids really don't need to be intubated. We just need to properly ventilate them by using either blow-by or small assisted ventilation. This, again, in adults, males and females from 6.5 up to 8.5, and children much smaller. You can use calculating 16 plus a child's age, divide by 4, or look at maybe the patient's little finger across their fingernail and try and guess what size to use for the ET tube. They're very small. And again, if you use a Broslow or hand Tevi system, you just open the correct drawer and the correct size is in there. Keep in mind that children have, for the most of the time, we use uncuffed tubes, but now they make very good cuffed tubes for children that are slightly different as you blow up the balloon. That is because children tend to have a funnel-shaped airway. Adults have a tube, and children have a funnel-shaped airway, larger at the top and much smaller at the bottom. Here's an example of an infant airway, about 4 millimeters across, and we're going to intubate them with a 2 millimeter ET tube, as opposed to an adult, which has a 20 millimeter airway diameter. And if we use an 18 millimeter 8 cuff or something, or 8.5, it's much, much easier. So take a look at the size difference and keep that in mind. Children, again, they have a large occiput. So when their head is flat on the table or a surface, it pushes their chin down and cuts off their airway. That's why we should always have about 1 inch underneath a child so that their occiput falls back and they've got this area exposed, so they're hyperextending their neck. This is another example straight out of the BLS book for CPR. A child, because of this large occiput, they tend to put their nose forward and the tongue will sit on their airway. That's why we put something underneath their shoulders to keep that airway open. Very often, the correct sniffing position, like we have here with a child, and just assisted ventilation with a small bag valve mask is all you need to maintain a child's airway. If there's trauma inside there or a lot of secretions inside there, that's something different. But most of the time, figure B is all we need to maintain good circulation and respiratory circulation in a child. Okay, as we move from airway to breathing, there are differences. Oxygen demand, chest wall compliance, smaller lung volumes, and they usually compensate with rate, meaning they get bradycardic with hypoxia. Remember, I told you that if a child starts to become bradycardic, and bradycardia in a child is pretty much anything below 100, but as they become bradycardic, that's usually a result of something going on respiratorily. They rapidly desaturate, so we got to keep the oxygen up. They're prone to contusions of their chest, and they can get a flail chest with fewer rib fractures. In an adult, a flail chest is a fracture in the front and in the back in more than 4 consecutive ribs, and that piece of the chest wall doesn't move well. In children, it might only take 2 or 3 ribs to cause that same respiratory problem. Remember, we should use a pediatric bag, and tachypnea is the earliest sign of distress. So rapid pulse and rapid breathing can show that they're having a problem, which could be leading to hypoxia. Bradycardia, slow heart rate, is usually secondary to hypoxia. It's been a while since we've, at least a year for most of us, since we've had the ability to gather at a EMS conference or a conference in general. Very often at these conferences, look around and there'll be a station where you get to play with adults and children. And I highly encourage you to go to one of those stations, and they'll run you through basic advanced life support, and you'll be amazed at exactly how slow or fast you wind up bagging pediatric, and you're really usually off. And they're kind of amazing if you have the wrong bag, et cetera, for size. And usually, it's free, and they'll be trying to sell you maybe a Braslo tape or something like that. But it's kind of interesting to try. So next time you see one of those, give it a try. Keep in mind, there are anatomical differences with breathing. The chest is usually much more compliant and soft. Here's a child early on who's developing a pulmonary contusion, and their ribs are not like ours. They're more horizontal, where our ribs tend to point down. And rib fractures usually indicate quite a bit of force because most of the ribs of children are cartilage. And things like a tension pneumothorax is more likely due to things moving around in the mediastinum here. Keep in mind that kids, we already know that they have a smaller airway size, and they don't have a lot of cartilage. And so they have a lot of cartilage, therefore their airways are a little sloppier than adults. They have less smooth muscle in their airways, a lot more mucus glands, so they have a lot more secretions. And they have difficulty then with collateral ventilation to other parts of the lungs. Because of that more compliant chest wall, things get injured underneath. And the diaphragm is slightly different, and they fatigue earlier than adults. So they have compensatory mechanisms. Their blood volume is smaller, and it's difficult to start an IV. So tachycardia, for the fourth time, is the earliest sign of shock in a kid. Hypotension, low blood pressure, is a very late finding. So early use of IO in these kids, if you futz around, that's F-U-T-Z. If you futz around trying to start an IV on a kid and they're crumping on you, just pull out the IO needle and give them volume. How do we do that? With isotonic saline, 20 mils per kilogram. That's our first bolus. Blood, if you've got a helicopter or if you're an agency that carries blood, most of the time blood is carried by advanced trauma units like a helicopter. It should be given after 2 boluses of crystalloid. Early use of plasma and platelets. In fact, in trauma, now the tendency is, if we can get it, to give whole blood that has red blood cells, plasma, and platelets to trauma victims. Bleeding of more than half the child's blood volume in the first 4 hours should be resuscitated with blood transfusions early on. There is some thought to permissive hypotension, meaning that we allow them to have a little bit of a low blood pressure if they don't have a traumatic brain injury. That allows us a little bit more time to get them into the operating room. But in general, we try and give them the bolus times 2, and then blood, and then we try and maintain them with a 4-to-2 rule. 4 mils for the first 10, 2 mils for the second 10, and 1 mil for every kilogram beyond 20. So again, in a normal range and percent of blood loss, as we start to get towards a half, you can see that kids will decompensate fairly quickly. So what are the alternatives? The Jamshidi, which is, you probably have one. It's old-fashioned, but it works well. It's hand-placed, blue, and you just screw it into, by hand into the tibia. The FAST system which is really designed for an adult sternum, not really used for kids. A bone injection gun, which is a Israeli device, which works like an IO, but it's spring-loaded. A very good device. It works very well. A little scary looking if you've ever used one. We use the EasyIO Pediatric. Keep in mind that think pink. If they fit on the Broslow tape, you're going to use the small pediatric needle. So again, think pink. If they're on the Broslow, use the EasyIO Pediatric. Here's the anatomy of proximal tibia and distal femur on a child. You can look at the compact thin-walled bone is way up here. The way that we say for IO is big toe, way to go. So we're always going to go medial. And you'll look at this cancellous bone that is just full of blood vessels and veins inside the bone. And access to this cancellous bone is almost automatically in their central circulation. Hundreds of small veins will add to the central circulation. In bones themselves, as we see this cancellous bone, the trabeculi, there's an artery and vein in each one of these osteons. So when the needle goes in, it's automatically in an artery or vein, and we've got instant access to the central circulation. Long bones have large, proximally, like a femur here, very heavy, very, very thick bone here, and that's not where we place the IO. These are trabeculi. These are the places that we put an IO. So when an IO goes in, it's into these trabeculi, and then down here in these trabeculi are multiple osteons, and those osteons have automatic artery and vein access. Here's one in the proximal tibia. You can see it goes in the proximal tibia, and it's in the medial tuberosity. Here's an IO in the medial tuberosity, and that's exactly where it fits when we x-ray it, and we can see that it's in there and instantly going into the circulation. The proximal tibia is thinnest medially, so if you go with the big toe, that's the way to go. You can see it's thinner here on the flat aspect of the tibia. So how do we find that? Here's a kneecap, 2 finger breadths below. That's where the patellar tendon inserts, and then we move finger breadth outside or medially. And here's our site in the distal tibia. We go down to the, again, big toe, medial malleolus. We can inject there as well. And the IO goes right into the distal tibia. In the distal tibia, the wall of the bone is the thinnest. Here's a fibula, which is way too small to get a decent needle in. Here's a child who is obviously dehydrated and looking sick. We can try and start an IV here, or up in the scalp. All of those places are difficult. I can do a cut down on the medial malleolus and try and find that saphenous vein. All of these are time consuming. When a quick zip with the IO will get things going. So again, we palpate where we want to go. We take the drill. You'll feel a pop. The best way to practice this is to take the pediatric needle and an egg. And when you practice on the egg, you'll get that feeling of a pop, and you'll know you're in the right place. You don't jerk it back. Once you get in, you simply disconnect and fix it. And they now have a large device that goes right around here, and it keeps us seated in place. And of course, it's a sharp, so you got to get rid of it. All right, now we're to the D part of ABCDE, and that's the disability or neurologic exam. Keep in mind that kids have larger head, so their skull development is slightly different. They have a different intravascular volume, and their development is different. So we get a higher amount of closed head injuries in children. It's possible for them to get skull fractures a little bit more easily. Because they're still growing, we'll get these growing fractures with intracranial bleeds. And the way we do a neurologic test or a glass glaucoma lets us know what their status is so we can monitor it. Brain injury is the leading cause of death and disability in childhood. 20,000 children acquire school-related disability each year. By the 10th grade, 1 in 30 kids have had some type of brain injury. For children and adolescents, 1 in a million, about 165,000 children will be hospitalized, with approximately 20,000 serious enough to cause lasting effects. Twice as many males as females, and for all ages, more than 2 million head injuries a year. Leading cause of death and disability in children. The younger the brain, the more vulnerable it is to the effects of injury. With adults, we try and simply get them back to where they were before the injury. Think of football. We have a concussion protocol. All we're trying to do is get them back to where they were before they got injured. But with children, we not only have to get them back, but they continue to develop. Beyond that, we have to make sure that we assure that they're going to develop normally. Types of closed head injuries, there's compression fractures can happen. They can get subdural bleeding, and they can get shearing through strains throughout the brain and swelling in the brainstem. I'll show you this a little bit more in a minute. Kids can get counter-coup injuries where they hit the front of their head, the brain accelerates, hits the front of the scalp, and then bounces back, and they can get injuries in the back of their brain as well as it hits the back of their head. That's called a coup, counter-coup injury. How does this happen in kids? Dropping and physical abuse, toddler falls, accidents, physical abuse, preschoolers, physical abuse, serious falls, and vehicular accidents. Keep in mind that each one of these categories has physical abuse in there. We have to be really wary of this, and I'll talk about that in a few minutes. Elementary school children, usually bike accidents or falls, or a sledding accident, are the major causes of injuring those kids. We can get what we call a subdural hematoma, where this is a dura mater. In Latin, that means tough mother. If you were to open up the skull of a child and look for the brain, you would find this heavy, almost plastic-like connective tissue over the brain. It's called the dura mater, or tough mother. And if you get bleeding under that, that's a subdural hematoma. And sometimes below that is the arachnoid. That's the brain lining below the dura, and you can get subarachnoid hemorrhage. We talked about herniation, and this is what happens when the brain begins to swell. Let's say there's a skull fracture and bleeding, and now the dura is pushed out and it's pushing the brain. We have these ventricles that are kind of the pressure differential for the cerebral spinal fluid. These ventricles can then squeeze and push the fluid out. But if we get to a point where this pressure is higher, we get this uncal herniation. This is in adults and children. And look where the uncus sits. It sits right next to the ocular motor nerve. That's why when you look at somebody's pupillary reflex and it's fixed and dilated, it's because they're probably having herniation in their brain and this ocular motor nerve is being pushed on and it's not working. We want to prevent secondary injury. Low oxygen and too much carbon dioxide are both bad. Low blood pressure, you want to keep that fluid going. If we have intracranial pressure, it can cause paralysis. So it's better to maybe get them intubated, control their pain, and we might need to put mannitol in there to get some fluid out of their brain. And we want to avoid hyperthermia and prevent and treat seizures, because an injured brain is going to have a much higher threshold for seizures. It's going to seize easier. Febrile seizures, for example, in kids are very typical, 6 months to 5 years. They don't last very long, and you usually only get one episode per fever, and it's usually tonic-clonic. And then atypical is anything from the above. So if you've got a head injury and you see a seizure, you really start to worry. All right, A, B, C, D, E, and we treat all the things that we can. And the secondary survey is a head-to-toe evaluation of a child after the basics. You're gonna go head to toe, scalp, teeth, look at their brain, of course, their scalp, their skin. I'm gonna see if there's bone exposed, is their brain exposed. Immediately, you do all your ABCs as we talked about. Keep in mind that the disability or Glasgow Coma Scale is slightly different for kids, and you may not see, you may just get grunts and cries and inappropriate words, and it's difficult with a young child to figure out what the GCS is. Keep in mind, you're going to be monitoring end-tidal CO2, and if you suspect that there could be herniation going on, you're going to hyperventilate that child to keep their end-tidal CO2 around 35. Most of you will get medical control for the use of mannitol or hypertonic saline. Maintain a normal glucose like you would with anyone else, and be careful that they don't have seizures. In general, kids who have a GCS greater than 8 do very well. If there's a GCS of 3, there's usually significant problem later on. You have to be careful of whether or not what their age is for comas, but you have to be very, very cautious and refer any child with a GCS of less than 14 for this neurocognitive evaluation. They need to be monitored very closely if they've had a head injury. Closed head injury, 95% of serious intracranial injuries are in infants less than 1 year are inflicted. 60 to 80% of the deaths are secondary to abuse, and always keep non-accidental trauma. That's a nice way of saying child abuse in your differential. If you suspect it, do a full non-accidental trauma workup. That means let the ER doctor know, let the police know that I just don't like this story. Keep in mind that if you suspect child abuse and you report possible child abuse and you're wrong, that it's okay, that you're protected. Again, we're back to the secondary survey. You're going to look at their chest, just like you would with anyone else. Listen to their heart, their lungs, look at their abdomen, look for external signs. I'll show you about that in a minute. A fast exam, which is an ultrasound, is a whole lot less reliable in a child, but there are radiation risks for using CAT scans willy-nilly. Abdominal trauma is the third leading cause of death in kids. Usually MVAs and bikes, etc. If I see a child go over the handlebars of either a dirt bike or a street bike and they fall off and go over the handlebars, I suspect that they have a spleen injury until proven otherwise. So that's a possible injury. Bladders can also get injured. You're going to look for blood pressure. Remember, it's a late sign in kids. And a lot of times, blood pressure is not very reliable in a child. Reassess them, reassess them, reassess them. Watch them very frequently. Handlebars and laptops, like I said, or lap belts, not laptops. If they go over the handlebars or they're bruised across their lower abdomen, I go ahead and irradiate them and get a CAT scan. So anytime you see bruising like this on a child, here's one from just a lap belt. Here's one from a 3-point restraint. Anytime I see the seatbelt sign, I suspect that something underneath is injured, and I'll go ahead and watch that kid, keep them a little bit longer, and usually I'll get a CAT scan on these kids. You can see that they can injure their liver. Here is a spleen that's injured, and you can pick splenic injuries up with the ultrasound. Kidney injuries are less common. Kids tend not to break their pelvis, but they can happen. And the musculoskeletal fractures, which we talk a little bit about, there's different classifications for breaking bones. These are called Salter-Harris fractures. Keep in mind that a child has a growth plate. So when you take a look at an x-ray, you're going to see solid bone in this gray area. And that gray area is where they grow from. That's where they add length to the bone. And there's different types of fractures through the growth plate. And anytime that a growth plate fracture is involved, you have to get them involved with an orthopedic surgeon. So in general, unique anatomy with kids, communicate to yourself, your partners, and the ER doctor. High index of suspicion for kids who are injured. Involve the family, consider abuse, and consider the risks of testing, meaning should you do a CAT scan or just watch them. A brief note about burns. Remember, kids are different than adults. Their head, 18% of their body, and their lower extremities are, rather than 18, they're 14. Child abuse is out there. It's 1 to 10% of all pediatric injuries, and it could be as high as 20. The younger the child, the higher potential for abuse. The right parent, the right child, the right day can all lead to an injury where a child is injured by an adult. 95% of the time, it's not some stranger, but it's the parents. They come from all types of groups, but if you are an abused child, that increases the number of times that you're going to abuse your children. Very often, economics play a role. It might be an unwanted child, accidental pregnancy, illegitimate birth, the opposite sex, what the parents wanted, a crisis period, or a former relationship. This former relationship, a stepmother or a stepfather, is probably the most dangerous. Some kind of crisis usually triggers the abuse when the coping mechanisms of the parents are overloaded. It could be money, unemployment, family arguments, absence of the other parent. All of these are possible. Neglect can be physical, or abuse could be just neglect, emotional abuse, or sexual abuse. Non-accidental trauma, we talked about that with head injuries. So kids with unexplained head injuries are the leading cause of mental status problems in kids. Multiple ages of children, and injuries out of proportion to the mechanism. A child who's 1 year old, when they fall down, they don't get hurt. Usually they fall on their bum or their rump and they're fine. And kids falling down the stairs, that's kind of odd. Kids in general don't even turn over until like the 5th and 6th month. So if you have a 3-month-old and dad tells you, well, he rolled off the bed, that doesn't make sense. Keep that in mind. Sometimes the behavior is too advanced for the child's development. Like I just said, kids that are less than 6 months old don't roll over or fall off the couch. If you get an inappropriate response, note that and put it in your note. Conflicting stories, talk to mom and then have your partner talk to dad and then get the history correct. If they don't have the same history, that's concerning. Remember that pre-hospital providers are mandatory reporters. That's true in the state of Oregon and most states. So if you suspect something and you don't report it, you could be at fault as well. It's your job. Don't expect the nurse to get it or the doctor to get it. They might be too busy and you were in the home and you saw it and it doesn't make sense to you. Let the nurse and the doctor know. Remember, reporting it is just an investigation. It's not an arrest. And I say that to people all the time. I've got a spiral fracture here, mom and dad, and I have to do, when I see a spiral fracture, I am obliged by the state to report it, and someone has to come and talk to you. Parents are usually fine. Okay, I'm fine. I'm okay with that. If they've got something to hide, they may not be okay with that. Those are just some references and resources. And if we have any questions, I'll take them now.
Hi, I had a question. So in the beginning, you said that 45% of pediatric deaths derives from trauma. Um, I guess when I read articles and read books and stuff like that, I'm always under the impression that hypoxia is like the biggest leading cause. So in trauma, is that the main reason, or is it more of like an organ, injuries to the organs?
Well, I think you're combining two different things. If a child gets abnormal vital signs and they're heading towards a code, hypoxia is the greatest reason that they're heading there, as opposed to injuries that bring a child into the emergency department. Half of the time, when children die, it's from trauma.
Okay.
Two different aspects.
Okay. And then my second question is for whether it was like pre-intubation or if you want to do put off doing intubation for a pediatric, would passive oxygenation work if you aligned their anatomy correctly, or is that kind of a wash?
No, most of the time, kids, as I said, remember when you intubate, what are you doing? You're giving them something that stops their breathing, stops their brain, and your skills of getting that tube in are less than 50% most of the time. So if you can control a patient's breathing with just proper positioning and assisted ventilation from a bag valve mask, that's probably a whole lot better. We tend to see that young children will do fine with proper positioning. Now, look inside their mouth and make sure that it's not full of vomit or it's not full of secretions. And if there's secretions, you're going to suck them out. But keep in mind that most of the time, kids will do just fine with just non-invasive means to help
Oh,
their ventilation.
would it also work with the nasal cannula as well for passive oxygenation?
Um, yeah, it could. And if they're showing any signs of distress, then you might have to help them.
Okay. I think that's the end of my questions.
Okay.
Albert, Lou, I think you were next about the blood pressure questions. Albert, do you have a microphone? Okay. He says no, so let me read up here and see what would happen. Okay, Albert's question said, because of the different blood pressure ranges for each age group, what would be classified as permissive hypotension for different ages?
Oh boy. Okay.
Ooh.
Well, put it this way: if we go back to that slide with all the blood pressures on it, permissive hypotension would be about 10 degrees or 10 millimeters of mercury less than normal. So in a 12-year-old, if you had 80 over 60 or 70 over 50 or something like that, again, with kids, as long as their heart rate's okay, most of the time that is more sensitive. Heart rate is more sensitive than blood pressure.
Okay, Albert's got another question. What would happen if a parent refuses treatment or transport for a child of suspected abuse? Or what if the refusal is based on religious beliefs, etc.? When does the emergency exception to consent apply?
Well, my standard answer has always been, you thought you smelled alcohol. And get the police involved early. You know, with kids, you've got some implied consent there because kids can't make a decent decision. Religious, I would get the police and lawyers, the DA involved right away. I wouldn't leave the scene. I'd wait until I'm talking to somebody smarter than me about the law and what can be refused. Now, if you suspect child abuse, and they say, no, I'm not letting my kid go to the hospital. I think if you tell the police, I'm suspecting that this is child abuse, all bets are off and they'll let you take that kid. And you would be on the right side of the law because if you suspect child abuse, you're a mandatory reporter.
Deborah, can you unmute your microphone and give a little more clarity to your question since that we've kind of gone past that topic?
Yes, my kid might start yelling, so sorry if he does. Um, for
No
the
worries.
for the ICP, you put that you could treat it with either mannitol or I can't remember what the other one was, but my service doesn't carry that, and the service I worked for before didn't carry either of those.
Right.
Oh, percent. It was 3%.
Yeah,
Well,
hypertonic saline. Those
yeah.
two are usually carried by Air Life or Life Flight or your helicopter or critical care unit. Most of the time, all you're going to have is, lactated ringers or saline, and that's fine to get the blood pressure up. And then if the blood pressure continues to go down, you're going to give a second challenge. And, if you're getting nowhere, then you're probably going to try and call in, air transport as soon as possible.
Okay, thank you.
All right, Deborah.
Menachem, do you want to unmute your mic and ask your question, or do you want me to read it?
Yeah, sure. I just want to know if a child would show Cushing's triad from increased ICP like an adult. I just know sometimes, in cases of earlier shock, they won't show their symptoms or at least their vitals till much later.
Not really. You don't get the typical Cushing's triad with children that often. It's more likely that they're going to get a persistent tachycardia that, and they're going to look like they're hypoperfusing. With kids, it usually, they're pretty resilient, but when a kid looks bad, they look bad. And I guess the only thing I can say is that's experience.
Thank you.
All right. Anybody else have any more questions? While we, for fluid resuscitation is the 20 cc's per kilogram for children up to 18 years old?
Yes.
Okay. Anything else? Anybody else got out here before Dr. Eschelbach closes up for the night? What is a good rule of thumb to know when to intubate a child? I know you don't usually intubate a child as readily as an adult.
Yeah. If their end tidal CO2 continues to climb and you can't correct it with bag valve or assisted ventilation, if there's significant head trauma, if their Glasgow coma score is less than 8, if there's abdominal trauma or orthopedic trauma where they're not going to be able to maintain their airway, go ahead. It's better to have a child with an airway in, and then you deal with the other things later. So ABC, airways number 1.
Excellent. Good questions tonight. Fantastic topic. Thank you, Dr. Eschelbach, for getting with us tonight. And I will have this recording posted on the MD Roundtable within a few days in case anybody wants to watch it again. So everybody stay warm and out of the cold. And I will give you credit for your roundtables and chats or whatever you need when I get it posted. Thank you so much. Good night, everybody.
Good night.